Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. When we talk about CT studies, we are talking about multimodal CT testing and its individual components. So what is multimodal CT testing and how does it apply? Can I start that slide again? Thank you. What is multimodal CT testing and how does it apply to acute ischemic stroke patient care? The publication listed here discusses what are the elements of multimodal CT testing. The first is a non-contrast CT. So the first part is to say, on the non-contrast CT, are there findings that preclude the use of IV, TPA, or other thrombolytic therapies? In other words, on the non-contrast CT, are there areas of hemorrhage, edema with shift, mass effect, or tumor? Or is there a large ischemic area that suggests that there is an old stroke present at the time of this evaluation? The aspect score, 1 of 6 to 10, which is good, suggests that there is a small infarct volume and likely improved outcomes after our acute interventions. But bear in mind that the non-contrast CT findings, such as the aspect score and signs such as the individual MCA sign, which is a clot present and visible in the middle cerebral artery, are less relevant than the first items we listed, which are those that would preclude the use of thrombolytic therapies. So in summary, the non-contrast CT is the industry standard first test and first component of multimodal CT testing. In considering these components, the second one from this article listed here by Wanamaker, we consider CT angiography, CTA. So when considering CTA, which is a study of the anatomic structure of the vessels in the brain and surrounding the brain, the first question is, are there extracranial carotid lesions? In other words, are there lesions in the internal carotids that might be a possible source of embolism and/or the presence of surgical lesion in the carotids in the neck? Next, we ask on CTA, is there a large vessel occlusion? We know that with large vessel occlusions, patients benefit from endovascular thrombectomy or EV therapies within 6 hours. And with CTA, we can also look at the efficacy or efficiency of collateral flow. In other words, with collateral flow that is adequate, a large core infarct is less likely, and an ischemic penumbra is more likely to benefit from acute therapies. Lastly, the multi-phase CTA helps to identify which is the core lesion or infarct and which is the ischemic penumbra, which is of most benefit or will benefit the most from our acute therapies. So considering our testing components from this multimodal CT and acute stroke article, the last we consider is CT perfusion, CTP. So when considering CTP, this is a test that tracks the flow of contrast as a bolus over time. It allows us to understand what is the size of the core infarct, because the core infarct size at the time of treatment does predict long-term outcome. And the CTP test also allows us to understand whether there is a large ischemic penumbra. A large ischemic penumbra supports aggressive care with IV thrombolysis beyond 4.5 hours, intraarterial thrombolysis, and/or possible other endovascular treatments up to 24 hours after stroke ictus, especially with posterior stroke problems. So what about multimodal CT as a diagnostic modality? There are 2 articles listed here that address this question about the multimodal CT testing approach. And why is this considered to be an optimal treatment or diagnostic step in our treatment paradigm for patients with stroke? Because with these tests, we can make treatment decisions based on vessel occlusion, the presence of collateral blood flow, and the tissue characteristics, both the size and extent of the core infarct and the ischemic penumbra. And this may better predict outcomes after reperfusion therapy than simply assessing how long it has been since the apparent stroke onset or ictus. This allows us to say that our acute ischemic stroke patient treatment is no longer just a time-dependent problem. It avoids the issue of not knowing for certain when the stroke ictus occurred, and it allows for better decision-making with patients with low NIH stroke scale severity strokes. Most importantly, it does allow the stroke patient care to be individualized to the characteristics of that patient's brain with regard to collaterals, the size of the core infarct, and the size of the ischemic penumbra, which may benefit from our acute aggressive therapies. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.